you prevent these infections. Other considerations, we know that IPs, that's the shorthand term for infection preventionists or infection control nurses, the staffing is low in many rural areas. So we have a lot of these nurses who are an army of one. They're in a hospital all by themselves, and they're primarily responsible for infection control. So they need as many tools as they can to help equip them to do this job well. They also need tools that help them switch between their complex tasks rapidly. So there can't be a lot of setup time, there can't be a lot of relearning as they move from one task to the next. We also know that many IPs are not statisticians. Most IPs come from the clinical side of things. And that's great because there's a whole lot of clinical involved in infection prevention. But there's also a lot of data analysis, predictive modeling that we can use to help detect issues in our environment, detect issues in our infection rates so that we can take action on that. So what we want to do is create solutions that provide the heavy lifting on the data analysis side. We also know that the infection reporting these days takes a lot of time. So infection preventionists will report infection rate data to the National Health Safety Network. But that also involves a lot of research, a lot of looking at charts and deciding which infections do I report and which do I not. And in some rural West Texas hospitals, we found that this takes up to 80% of the infection preventionist time. So anytime we can save them in their other tasks is a big win for them. We also know that, like we talked about in some of the previous conversations today, department and data silos are still present. And so this is always a challenge in healthcare. How do we share data? How do we centralize it to where we can use it together to make better decisions? And then really closing the gap on the technical and the clinical, bringing those two things together in the position is really what the key to success is. Whenever we talk about infection prevention, we always talk about the chain of infection. So this isn't something we invented. This is something that all infection preventionists use. And I just wanted to give you guys a really quick outline of this because I'll mention some of these terms. In order to have an infection, I have to have an infectious agent. I have to have bacteria or virus that can cause an infection or an illness. The reservoir is simply, where is that at? Is it on the healthcare worker's hands? Is it somewhere in the environment? How does it exit that to then transmit? And that's 3 and 4. And then how does it enter into the susceptible host? Is it through a surgical site? Is it through mucous membranes? Do they inhale that? And so as we talk about this, you may hear me use the term reservoir or something. It's not really critical that you understand the whole chain here, but I just wanted to give you an overview. So the goals for our software are this. We want to simplify the way data is collected. We want to make it really simple. We want to template things as much as possible. We want to automate. We want to do all the heavy lifting on calculations, any non-value adding tasks, so that the time that the infection preventionist spends with this software is really valuable and it's really purposeful. We also want to centralize the data, so we know that the two big departments that we talk about when we talk about infection prevention are environmental services. You may know them as housekeeping, but now we've kind of changed that term as well. And then infection prevention. We want to figure out how do we bring data in from both of those and make them work together. And then we want to be proactive. Or if we can't be proactive, we want to be as reactive as possible. And so in some cases, I'm able to detect an issue before it becomes an infection. And that's really where I want to be. I want 0 infections if I can do it. In some cases, I want to detect it at infection 1 or infection 2, not wait until it gets to infection 14, 15, and we don't need a data system to analyze it. It's obvious we've got an issue. So let's talk about the first thing that we want to look at. How do we define clean in the environment? There's 2 ways that we typically did this in a hospital. We would look at it and we'd say, okay, it's visually clean. So through visual inspection, we get a really rapid result. We can decide it looks clean, it smells clean, I'm going to judge that clean. The bad thing about that is we know that viruses, bacteria can live on those surfaces, but we don't see them. And so while it's really fast, it's not necessarily accurate. And then conversely, what we could do is we could take swabs and we could transfer those to Petri dishes. We could culture those, and about 24 to 48 hours later, I could count colony forming units, and I could say, okay, I know exactly what's in that environment. I know how much of it is there, but it takes a really long time. And so in 48 hours, I can't hold that room for 48 hours, and so I've potentially exposed another patient or another couple of patients to that area in that time. So we're kind of faced with a trade-off of, do I go for fast and inaccurate or accurate and slow? Well, we kind of had a Medici effect moment. And there's this book called the Medici effect that looked at marriages between industry and nature, or industries that didn't necessarily match up. And that's really what we found here. We didn't invent this technology. Technically, fireflies invented this technology, but it's a really cool technology, and it really gives us a good insight into the environment. So fireflies combine two things to create light. They combine adenosine triphosphate, called ATP, and they combine it with a coenzyme called luciferin. And the luciferin takes the ATP, which is simply, you can basically think of it as an energy molecule within all living cells, and it converts that energy to light. The great thing about this reaction is the more ATP we have, the brighter the light is going to be. So what I can do with that is I can swab a surface, and I can collect any living tissue or any living matter that I find on that surface. I can then combine it with the luciferin in that swab, and I can put it in this meter here called a luminometer, and it's going to measure light output. And there's a whole host of reasons why we love ATP. First of all, it's quantitative, and it's not qualitative. With something like a visual inspection, it's a pass-fail, and it's very subjective. So what passes for me may not pass for you. But we get a number there, and we know through studies that there is an acceptable level of ATP present on a surface, and there's an unacceptable level. The next thing is it's ratio data, so it's great for statistics. If you're a data guy like me, I'll kind of tell you what ratio data means. It means I've got a true zero value here, so if I get a zero in the meter, it means there's the absence of ATP. That's really good for statistics. The other thing is that the data will move, or the numbers will move the way we think numbers should. And so it's not a 1 to 10 scale where we don't have strictly defined barriers. 200 is truly twice as high as 100. So that makes it perfect for doing some data analysis on. And then it's rapid, so I can get a numerical value that I know is a pass-fail and a true valid pass-fail in less than a minute. The great thing about ATP is not that I take a single ATP sample and I make a decision on it. The great thing about ATP is I can collect a whole bunch of ATP samples. I can then start to average those by, say, maybe each day or by week or by month, and I can start to look at trends in my data. I can analyze the different departments or floors or areas of concern, and I can look for spikes. And so I've got a spike in this little example chart here, and I can start to dig in and see, okay, where are the outliers or where are the high values that are leading to that spike? The great takeaway from ATP is that I'm not waiting to react until I have an infection. I'm actually before the infection. So when I detect an issue with my environment, I can take proactive steps to help counteract or help eliminate those reservoirs in the environment before an infection occurs. And that's truly changing and saving lives because we don't have to wait for one person to suffer. Hand hygiene is another area that we have found great success in. And I put simply difficult on here. This is the template or the foundational work from the World Health Organization for hand hygiene compliance monitoring. We all know that hand hygiene does save lives in the healthcare space, and that's a big part of the infection preventionist's job, is to audit their staff and ensure that they are truly washing their hands when they should. I put simply difficult up here because the World Health Organization used to name this form the simple form, but it's really, really complicated, so I felt like I always had to do the Dr. Evil finger quotes whenever I said simple. But it's not that easy to fill out. There's a whole lot of data you have to fill out. You would start out with observations on the first page. You would then move and transfer some data to the second page, and then you'd transfer some more data to the third page to get your raw numbers. From there, you're not even really done with this. You're then taking your numbers and you're creating some sort of chart, graph, table that helps communicate the results to your staff. It's a really long process, and a lot of it could be automated. So instead, what we did was we left the observation part on the IP's desk, but we took everything else out. We took everything else off. So we do the heavy lifting on the calculations, on the reporting, and we leave them to do the observations. This is an example of the form that we use, and so we collect the same observational data, but all they have to worry about is filling out one form. It's really easy to train other staff on this as well, so they can rely on nurses or other clinicians to help peer audit each other, giving you time to get more data and a more robust reporting system. These are just a sample of some of the reports that you can get that before an infection preventionist would have to spend time building. Now all they have to do is do the observations and they can move on to the next task because the report's already built. Infection mapping is probably one of the coolest newer things that we're working on. When we first started the company, I read this article from AGIC, and it was talking about the history of infection control and epidemiology. And it talked about Dr. John Snow, and he's regarded as the father of modern epidemiology. So cholera outbreaks in the 1800s London were a really big deal. In 1853, over 10,000 people died from cholera. In 1854, Dr. John Snow was practicing in Soho in London, and a cholera epidemic started. It was violent and it was sudden. So in the first 3 days, 127 people died. Over the course of 10 days, 500 people died. And back then, we didn't have germ theory, or it wasn't very popular like it is today. And so people thought it might be smells. They really didn't know where to attribute it. And so if you had money, you just moved out of the area and you waited for the cholera epidemic to subside, and then you'd move back in. But a lot of people couldn't do that, especially in London. Dr. John Snow was a believer in germ theory, and he started doing an investigation. And he created this now famous map where he started to plot where people had been. And he found that when he started to do this, everything clustered around the pump on Broad Street, the water pump. This was before indoor plumbing, and so people would retrieve their water from various pumps throughout the city. And he determined that the most likely cause was this pump. He talked to the city council, and they removed the pump handle, and then the cholera epidemic subsided. He saved a ton of lives by doing this. So we were talking about this, and how do we take a cool concept like this and apply it to our software? Well, we know that there can be environmental reservoirs, just like that pump handle, in our environment. We looked at the journals, and we found that if we were looking at equipment that was used and cleaned by nurses, studies show that about 50% of it is clean if you tested it at any given time. And then we looked at rooms that were terminally cleaned by EVS and checked surfaces there. So unsurprisingly, we found about the same value there. So we know that there's a risk for those reservoirs to exist in the environment. The scary statistic is actually from a Columbia University study that showed if I discharge from a room and you are the next patient, you're 5.83 times more likely to get my infection without us ever having met or seen each other. And that's because the bacteria that I leave in the environment is likely to get picked up by you. So there's a lot of incentive for us to detect these patient-to-patient infections through the environment early so that we stop it at infection 2 and not infection 14. Another thing to mention real quick is we can also prevent cross-infection. So if we've got a lapse in processes in isolation protocols, or we're sharing equipment among people with infections, or one person who has an infection, we could transmit that from one room in a department to another. So we can also use the mapping to detect that. Here's an example of that map. So this is a medical ICU, and green means everything's good, we haven't had an infection there. Yellow means that within the time frame we're looking at, we've had one infection, but it's isolated. Maybe in 302 we've got a C. diff infection, but we don't have a C. diff infection in any other area of that department. However, in room 309 and 310, we have those showing up red. And that means that we've either had a back-to-back infection, so one patient had a positive lab result on 4/1, and then we had another one on 4/7. That may suggest that the environment is passing that infection from patient to patient. If we can catch it that quickly, then we could have changed and saved the lives of 6 more people who would occupy that room after that. It may also tell us that we've got a potential cross-infection issue with 309. Maybe we've been sharing equipment, or we're not good at isolation protocols, or our hand hygiene needs some retraining in that area. So what the map does is it just highlights potential gaps in our processes and helps us know where we do our investigations. The final thing I want to talk about is employee challenges. So we know that, leaning back on those statistics that we just talked about in the environment, that despite our best efforts in the healthcare industry, environmental services, nursing staff are not always the best at disinfecting equipment. And so how do we engage with them more? How do we get them the right training, guided training? How do we get them to just engage more with their career so that they care more about the quality of the disinfection that they're doing. We found that as we started to look at the training is often done in an initial event, maybe an orientation, and then some peer training with the veteran EVS technician in the area. From there, feedback is just a little bit sporadic. In a lot of hospitals we talk to, feedback usually occurs about every 6 months where we do an employee evaluation on that person. And in some cases it can go as long as a year. It's typically a single event, meaning we're not building upon our previous evaluation. We're saying, this is how you did today in my one observance. And then 6 months later, this is how you did today in my single observance. But I'm not putting those two records together so I can show a history and a growth. And that's where we talk about snapshots, not timelines. So what we did was we created a templating system. What we found was when we started talking to EVS supervisors on why they don't do more observations, they didn't have templates, they didn't have audits, they didn't have forms that they could easily rely on to help perform those quickly. So we created a system that allows them to create template audits. We usually recommend they're 10 to 20 questions so they can be done very rapidly. And then they don't have to worry about bringing all the data together. They just record their observations, and then it goes ahead and builds the scorecard. This provides the employee and the supervisor with real-time knowledge about the performance of that employee, and it also gets that employee engaged because they know where they're good, but also where they need to work on things. From here, they can also look at, if I'm weak in floor care, I can use this same system to call up protocols on floor care, or I can watch a training video on floor care. So it empowers them to proactively increase their knowledge in those areas as well. That's the last thing I had for you today. I hope this was informative. I know everybody in here is not in the infection control space, but I hope maybe this has spurred some creative ideas in your own space as well. Thank you.